This is Ken Newbill, President for Advocacy and Awareness for Immune Disorders Association, or AAIDA, located here in Charlotte, North Carolina, and I'm happy to be hosting today's educational webinar. AAIDA's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAIDA works to promote research and create better awareness for immune disorders. This is AAIDA's 7th of 12 educational webinars for 2021, and today I will be joined by rheumatologist Dr. Delfin Santos, who will be discussing Sjogren syndrome. It's not just dry eyes and dry mouth. A little bit about Dr. Del Santos. Dr. Del Santos has been in private practice for 28 years and currently serves as director of AARA Rochester Rheumatology Center in Rochester Hills, Minnesota. He is on the teaching staff of Wayne State University Internal Medicine, Family Practice, and Traditional Residency Programs. Dr. Santos earned his medical degree from UCMM in Santiago, Dominican Republic. He completed his Internal Medicine Residency Program at West Suburban Hospital Medical Center in Oak Park, Illinois, where he was chief resident. Dr. Santos completed his fellowship in rheumatology at Rush Presbyterian St. Medical Center in Chicago, Illinois, and served as chief of Department of Medicine and as vice chief of staff at Ascension Hospital Medical Center in Rochester Hills. Dr. Santos is a consultant in rheumatology at Beaumont Hospital and at Ascension Hospital Medical Center, and the rheumatology consultant for the Michigan Department of Corrections, and is consultant on the Speakers Bureau for various pharmaceutical companies. Dr. Santos has been on the advisory board for the American Behcet Disease Association for the last 20 years and is repeatedly named top doc in rheumatology in Our Magazine Detroit. Thank you so much, Dr. Santos, for being here with us today.
Well, thank you guys for having me, and it's really, truly a pleasure to speak on this subject. As Ken mentioned, I've been practicing rheumatology for more than 28 years, and I truly enjoy what I do. I think this is a great field, and autoimmune diseases are so varied, and when the residents rotate through my practice, they're really amazed at the variety of different conditions that we see. And just to correct one thing you said, Ken, I practice in Michigan, not Minnesota. But
thank
you. You're welcome. So today, what I want to do is talk about Sjogren syndrome, and it's truly not just dry eyes and dry mouth, although those are the major manifestations and what really brings people generally to my practice. So today, I'm really going to focus on primary Sjogren's because we divide Sjogren syndrome into primary and secondary. Primary Sjogren's is a disease in and of itself. A lot of what we talk about will be consistent with secondary Sjogren's also, and many people that do have Sjogren's have primary rheumatoid arthritis or lupus or other autoimmune disease with secondary manifestations of Sjogren's. So what I talk about will relate to both, but a lot of the sequelae and the more serious manifestations of the disease are really in patients who have the primary Sjogren's. It's a chronic autoimmune disorder. The cells actually are attacking your body, mostly the exocrine glands. Most autoimmune diseases are of that kind of scenario where you produce autoantibodies that come and attack your tissue. And Sjogren syndrome is not just eyes and mouth, it can also affect the skin, vaginal dryness, many internal organs, kidneys, blood vessels in the form of vasculitis, which is inflammation of the blood vessels, lungs, liver, pancreas, brain, pretty much most parts of your body. A lot of people haven't heard of Sjogren's, and when I diagnose somebody with it, they're not familiar with the condition, yet it's the second most common rheumatic autoimmune disorder, secondary to rheumatoid arthritis, which everybody's heard about. There are no geographical differences. We see it all over the place. It's all over the world in very similar prevalence. In the United States, there are about 500,000 to 2 million patients, depending upon what criteria is used to diagnose the condition. Average age is 40 to 60. Rarely do we see this in patients before the age of 40. And as we know with a lot of other autoimmune conditions like lupus, 9 out of 10 patients are women with Sjogren syndrome. Henrik Samuel Conrad Sjogren was the Swedish ophthalmologist who really described the symptoms of Sjogren syndrome, and he kind of fathered the what we know today of the condition, and coined the term keratoconjunctivitis sicca, which now is used synonymously with Sjogren syndrome. We really divide the symptoms, the clinical features, into two groups: the exocrine or glandular and the extraglandular or systemic. And I'll talk about each one of these so that you can understand how these symptoms come about. So as I previously mentioned, the eye symptoms and the dry eyes and dry mouth are the major manifestations. And the keratoconjunctivitis sicca, in this picture here, this eye has been stained, but you can see down at the bottom of the cornea, the brown part, down at the bottom, you can see red where the stain is taking or is causing some inflammation or stain there, and this is due to scarring of the retina. So when the dryness is severe enough, you get scarring of the tissue, you can have corneal injury, and it's very, very uncommon. If any of you suffer from this, you don't have to, I don't have to tell you how bad the symptoms can be, not only in the eyes, but in the mouth. And patients can't wear their contact lenses. They have to constantly use eye drops. And it's hard to read for any extended period of time, very uncomfortable. The mouth is the second most common manifestation, and patients have difficulty chewing, swallowing. They have a lot of pain. Saliva is actually antimicrobial. When you don't have saliva, you're more susceptible to infections, not only bacterial, but also fungal infections. Patients can get these fissured tongue, as you see in the upper picture, angular cheilitis, which is that chafing and irritation at the sides of the mouth. Very uncomfortable, and these symptoms are very difficult to control. So the glandular manifestations aren't just the eyes and the mouth. I mentioned that vaginal dryness can occur, and women that are premenopausal that develop this have difficulty with the dryness. Once they go through menopause, it even exacerbates this and makes it much worse, causes painful intercourse, and it's very difficult. A lot of dry skin, upper respiratory tracts, there's mucous membranes and glandular tissue in the lungs. And when people dry out, they have coughing and they can develop bronchitis. And sometimes it's this chronic dry cough and shortness of breath that's very difficult to get rid of. Patients can develop musculoskeletal symptoms. And I frequently see patients with joint pains, and sometimes, and remember I mentioned this is the primary Sjogren, sometimes we'll see symptoms that suggest rheumatoid arthritis when it's all a manifestation of Sjogren's, and there isn't a severe inflammatory arthritis. Patients with Sjogren's, unlike rheumatoid, generally don't get erosions. That's where there's damage to the joints. The fingers, wrists, ankles are the most common, but shoulders, hips, and knees can be affected. In the lower picture there, that's a condition called Jacquard's arthropathy. And the difference between that and somebody with rheumatoid, you might have seen a hand that looked like a rheumatoid hand, is when this person makes a fist, it looks like a normal hand. It's reducible, reversible, and when you look at an x-ray of this hand, there's absolutely nothing that you can see that's damaged or causing erosions like we would see with rheumatoid arthritis. This Jacquard's arthropathy is not only seen with Sjogren's, it can be seen with lupus and other conditions. One of the major manifestations of Sjogren's and a lot of our autoimmune conditions is fatigue, and I can tell you that this is very disabling. We try to use different treatment options. We try to get people to exercise, regulate their sleep, but fatigue seems to be a major issue and one of the more disabling aspects other than the dryness. Salivary gland involvement and enlargement is also a common manifestation. This is generally bilateral, it's firm, and frequently asymptomatic. These patients, other than having the big swollen glands, don't have a lot of pain, although they can be painful. So you can see a couple of examples of parotid gland enlargement. Patients look like they have the mumps. And on the right, you can see some MRI scans showing the very enlarged lymph nodes, or the very enlarged parotid gland. And patients with Sjogren's, as I'll mention and show you in a little bit, are at increased risk of lymphoma. So when anybody gets a swollen gland, you have to make sure that we're not dealing with any type of malignancy. There are different ways to evaluate Sjogren's patients, and there's diagnostic criteria. For the sake of this lecture, I didn't get into the diagnostic criteria. Those are mostly used as classification criteria for clinical studies. In the office, we're not necessarily putting people through some of these things. For example, a Schirmer's test, you can see that little strip of paper coming out of the eye measures the moisture in the eye, and if there's less than 5 millimeters of moisture on the eye after 2 minutes, it's a positive Schirmer's test. Rose-Bengal staining, as I mentioned previously, on the right there, you can see that red staining and that little area of inflammation and scarring and at the lower part of the cornea. Salivary flow studies can be done to determine how much saliva somebody's producing. We do not do this in clinical practice. These are mostly for clinical studies. And then dental evaluation is very important because of the high incidence of caries and mouth sores and fungal infections in the mouth and the complications related to the very severe dry mouth. Going on to other extraglandular manifestations, patients with Sjogren's can develop pulmonary problems, and they can develop bronchitis and the shortness of breath and cough. More advanced disease, and we see this with other kinds of autoimmune diseases, patients can develop interstitial lung disease. And this radiograph, this CT scan that I'm showing on the left lower side there shows honeycombing that is classic for interstitial lung disease, and this can be quite severe. Luckily, it's not a common manifestation. In my 28 plus years of rheumatology, I've had one patient, an unfortunate young lady in her 40s, who developed severe interstitial lung disease and died from her lung problems. That's the one patient I can tell you that's had that severe of lung disease, and I've seen hundreds into the thousands of patients with Sjogren's syndrome. I can also tell you that some patients just have mild symptoms and mild problems, and it doesn't turn into this life-threatening condition. Kidneys can be involved, and patients develop interstitial nephritis, lymphocytic infiltration into the kidneys, so it's the immune system attacking the kidneys. Luckily, most of the time it's a subclinical course. What this means is patients aren't aware of it. We're not seeing a tremendous drop in kidney function, and sometimes there can be low platelet counts and some calcifications in the kidney, but for the most part, it's just a mild chronic renal compromise, if at all, in these patients. Sjogren's can affect the brain, and when affecting the brain, there can be psychological manifestations. So these psychopathological features can vary depending upon what the premorbid personality traits of the person were, and it usually is due to antibodies attacking the tissue in the brain. So there can be neuroticism and psychoticism and obsessive compulsive disorder, hypochondriasis, paranoid ideation. Again, luckily, these things are not real common, but just showing the wide scope of Sjogren syndrome and the fact that it's not just dry eyes and dry mouth. The biggest concern that we have with Sjogren syndrome is that there's a higher, let me put it this way, higher incidence of non-Hodgkin's lymphoma that can develop in these patients. Now, I listed here the different conditions showing the standardized incidence ratio. Just so you know, if you're non-medical, incidence ratio, if you're at 1, that's equal to what you would expect in the general population. So autoimmune diseases in general are at about a 1.6 odds ratio or incidence ratio, excuse me. Sjogren's, looking at all these other diseases, at 4.9. So there's a higher incidence of non-Hodgkin's lymphoma in patients with Sjogren's syndrome. Lupus is up there, 4.4, but not as high. Rheumatoid, we always talk about the incidence of lymphoma is at a 2. And then you can see some of the other conditions there. So we're always vigilant, and I'm always checking my patient's lymph nodes. If somebody gets a swollen parotid gland and it's symmetric bilateral, that's usually low likelihood of lymphoma. So a bilateral large parotid glands is not a good thing to have, but it's not something to be suspicious for the lymphoma. There are some things that patients with Sjogren syndrome can develop, and some things that would put them at a higher risk of developing non-Hodgkin's lymphoma. So patients can develop peripheral neuropathy, and neurologic manifestations are not only psychosomatic or psychiatric, as previously mentioned, or even parenchymal in the brain tissue. It can cause peripherally nerve irritation and peripheral neuropathy. It can affect the kidneys, as I mentioned, the blood counts, purpuric lesions, and I put a picture there of what purpura looks like. Purpuric lesions are a form of vasculitis. That's an inflammation of the blood vessel. If we see these things, we have to just remain vigilant that someone could be on the verge or even low-grade non-Hodgkin's lymphoma. Other things, we look for blood tests, low complement levels that are frequently seen with lupus, but also can be seen with Hodgkin's, and cryoglobulinemia, which is it's a form of autoimmune disease that generally is seen in patients with hepatitis C, but can be seen with other autoimmune disease states. So when we're looking at a patient initially with Sjogren syndrome, we're going to do generalized blood work, complete blood count, chemistry profile, urine test. There's a couple of blood tests that are very helpful for Sjogren syndrome, and that's the SSA, SSB antibodies. They're also called Rho, anti-Rho, and anti-La. These antibodies have been shown to be prevalent in patients with Sjogren's in about 60% of patients. And that's interesting because that leaves 40% of patients with Sjogren's who never show up in the blood. Now, there are other antibodies that can be there. A good percentage of patients with Sjogren's will have a positive rheumatoid factor. And that's also important to note because not everybody with a positive rheumatoid factor has rheumatoid arthritis. So we have to differentiate Sjogren's from rheumatoid, especially if a Sjogren's patient has some joint pains. We don't necessarily diagnose them with rheumatoid arthritis because the rheumatoid factor is high. Other tests, ANA, the SPEP, which is a serum protein electrophoresis, looking for any abnormal proteins in the blood. I mentioned cryoglobulins, and then hepatitis C and HIV are done just to exclude other conditions that could cause similar manifestations to the Sjogren syndrome. The definitive diagnosis could include a salivary gland biopsy, and so we do minor salivary gland biopsies in the lower lip. I'm one, and in my practice, and not all rheumatologists agree on how to do things. I don't do a lot of salivary gland biopsies unless we need a definitive diagnosis because it doesn't change the treatment. If a patient wants to know 100%, do I have Sjogren's? If they don't have the SSA, SSB antibodies and other symptoms of Sjogren's, then I will send them for a salivary gland biopsy. In most of the patients that have mild disease, it doesn't change the treatment, and it's invasive and it is painful. So I reserve the biopsy for confusion states when I'm not 100% sure what's going on. And then it depends on what they find. If you can see on this slide on the left, there's two areas where there's these dark clumps. Those are white blood cells attacking around the glands, and that's what we look for when we do the biopsies. There are a lot of conditions that can mimic Sjogren's, and so when we do clinical studies, there are exclusion criteria that we don't want to include these patients in the clinical trial because we're probably dealing with other conditions. And these would be patients who have had neck and head radiation. Those patients frequently will have sicca, which is dryness that's not autoimmune in nature. Hepatitis C, as I mentioned, AIDS. Patients with pre-existing lymphoma can have dryness. Sarcoidosis, which is a autoinflammatory condition that causes a lot of inflammation, can cause swelling of the lymph nodes and glands. Graft versus host disease, patients who have had organ transplants and might be losing or rejecting their organs. Many medications, so there are medications, anticholinergic drugs, antihistamines, patients who are taking drugs for ADD, some of the things like Adderall and amphetamine type of derivatives. Those type of medications all can cause severe dryness and have to be screened before we can diagnose somebody with Sjogren's syndrome. The differential does include the medications that I mentioned, different infections, tumors, so patients can have enlarged glands, parotid tumors. They can have mumps as the initial presentation, conditions called amyloidosis, which is abnormal protein production, autoimmune related diseases. There's a condition called IgG4 related disease, and that can cause swollen glands, specifically into the submaxillary glands. And also autoimmune thyroid disease can cause some of the manifestations of Sjogren's, and this needs to be ruled out. So how do we treat the condition? Well, it's really important that we discuss lifestyle changes, and we have to talk to patients about what they can do to kind of help their symptoms. There's over-the-counter products, and then there's prescription drugs. So patients will, if they live in for example, in the desert, you might talk to them if they're in Arizona about moving to a more temperate climate. If they live in the northern states where we have heat in the wintertime, we want to make sure that they have good good moisture, maybe set a glass by their bed at night, and try to avoid things that are going to dry out their eyes. Certainly avoid drugs that will make things worse. Make sure their humidifiers are working properly and things like that. There are over-the-counter artificial tears, just saline drops that can be used, and these patients will carry these with them and use them on a regular basis. There are prescription drops, Restasis, which is a cyclosporin preparation that is used in the eye. Sometimes Restasis, which is immunosuppressive, can cause burning in the eye when it's first put in, and some people have a hard time tolerating it. It doesn't work for everyone, and since it does suppress the immune system, we do have to keep an eye on any signs of infection. Patients who have contact lenses frequently can't wear them when they have the dry eyes, but if their dryness isn't that bad and they're using Restasis, we don't want them to use the eye drops because it increases the risk of infection. The Zidra is another prescription drug that can help increase the tear production. One thing that many of my patients aren't aware of is that there are autologous eye drops. What are autologous eye drops? These are eye drops where you go to the place that makes these for you, generally some ophthalmological office, and you're the donor and the recipient. So what they do is they draw blood, they spin it down, and they pull out the serum, and they make eye drops. These eye drops are diluted with sterile preservative-free solution, and they produce a tear substitute that's unique to that particular patient. Very soothing because the pH and the salinity of the product is the same as your tears, and patients that aren't getting any benefit from these artificial tears really do well with this. The problem with this is it does have to be refrigerated. When you go for the preparation for them to mix it, they do have to draw the blood. They do charge, and I think on average, it's around $100, $125 to get a couple months supply of this autologous eye drops. But certainly something that's beneficial for patients that don't have any alternatives. And so the typical draw is anywhere from 6 to 8 bottles, and it will produce, as I mentioned, enough for about 1 to 3 months. Prescription treatments. So there are over-the-counter and prescription non-steroidal anti-inflammatory drugs that can help with the joint pains and the muscle pain. Also, there are some non-steroidal anti-inflammatory eye drops. Corticosteroids we can use, and if the eyes are very irritated, they might use it for short term. We don't like to use long-term corticosteroids. We don't like to use oral long-term corticosteroids because of all the secondary sequelae and long-term side effects of steroids, which include many things from diabetes to osteoporosis to poor wound healing to cataracts to bruising of the skin, weight gain, high blood pressure. The list goes on and on. So as many of you are aware, steroids are not first line. They might make you feel better, but certainly not something we want to keep people on for a long term. Disease-modifying anti-rheumatic drugs. So there are a lot of different medications that can be used. A lot of rheumatologists will put their Sjogren's patients on hydroxychloroquine. I'm sure a lot of you are familiar with hydroxychloroquine. There was a lot of discussion about it last year with COVID and whether or not it reduced the symptoms of COVID. And we'll leave that for another day. But unfortunately, there are studies showing that hydroxychloroquine doesn't really improve the dryness of Sjogren's syndrome. When do I use it? I use it for patients who are really fatigued to see if I can get some improvement in fatigue, and patients who have significant joint pains. There are other biologic drugs, some of the drugs we use for rheumatoid, and other small molecules that are also used for rheumatoid that could be beneficial, but these medications are not FDA approved for Sjogren's. They're very expensive and hard to get. There are dry mouth prescription treatments, artificial saliva, biotin, over-the-counter Xylamelts, which is this little capsule. It's kind of a neat little thing that you peel off the back and stick it on your gum at night when you go to bed. By the time you wake up in the morning, it's dissolved, and it really helps keep moisture in your mouth. And then the dry eye prescription medication we've already talked about. So these are some of the disease-modifying drugs that we use. I mentioned hydroxychloroquine. These other ones, methotrexate, azathioprine, Cellcept, leflunomide, and the cyclosporin. These I reserve for patients with more severe manifestations, and these are generally used in patients that have the extra glandular manifestations, possibly interstitial lung disease or kidney problems, or patients that have significant joint pains. But for the most part, I don't put these patients on these drugs. Patients that maybe have severe neurologic manifestations might need some of these immunosuppressive drugs to control their neurologic symptoms. There are stronger, more aggressive therapies such as cyclophosphamide, which is a pretty nasty drug that can be very helpful and life-threatening if there's associated vasculitis. Rituximab, which is a drug that, interestingly enough, is also approved for B-cell lymphomas. So it's a medication that can be very helpful if somebody has severe manifestations. There's actually less severe side effects from rituximab than potentially from cyclosporin. There are oral systemic therapies, Evasac and Salogen. These are cholinergic agonists. Anticholinergic drugs cause a lot of dryness. Cholinergic agonists will produce tears and saliva. Works better on the mouth and the tears. And these are medications that are taken multiple times a day. Side effects could be some sweating and maybe some increased urination, some diarrhea. But for the most part, they're very good if you have severe dry mouth. And they're not too expensive, and most insurances will cover it. The Nutricel is a product that comes in a powder. You mix it in some water. You swish it around in your mouth, then you spit it out, and then do it again. So you do it twice, and it really helps. I've had a lot of patients who tell me that this works the best for them as far as helping with their saliva and keeping moisture in their mouth. So if you have that problem, talk to your doctors about the Nutricel. One of the most common extraglandular manifestations would be peripheral neuropathy. And this is where you get some burning in your feet, burning in your hands. This is estimated to occur in anywhere from 8.5 to 70% of patients. And peripheral neuropathy is actually very common in other conditions, diabetes, rheumatoid arthritis, also what we call idiopathic, which basically means we don't know what causes the peripheral neuropathy. But it can be seen with Sjogren's, and the treatment is as you would treat any other peripheral neuropathy with medications to try to lower the try to lower the inflammation in the joints. The central nervous system is rarely involved, and it's much less common, luckily, because these symptoms can be very severe. In any case, in these patients with neurologic involvement, we need neurologic evaluation to help us diagnose the condition. So, general recommendations when you have patients with Sjogren's, we want them to follow good oral hygiene. This prevents gum disease and infection. We do want them to use the artificial saliva, saliva stimulators. Chewing gum that doesn't have sugar in it, you do not want to use any of the products with sugar because it'll increase the risk of cavities. And you can use sour lemon lozenges, which do produce an increased saliva production. Obviously, consume more liquids. There are topical fluoride and antimicrobial rinses to help prevent cavities. Biotine products, toothpaste that can help. There's salivary substitutes, gels, rinses, sprays, and there are organizations I'll mention at the back where you can get a lot of information to help you with these products. If you're a smoker, smoking is a bad thing, not because of everything else we know about smoking with the cancer and emphysema and all that, but because of its effects on the mouth and saliva and the irritants to the mouth, and so really important to try to give that up. And then we recommend people see the dental hygienist on a regular basis. Resources. Obviously, AAIDA, that's sponsoring this lecture, is a good resource for this and many other autoimmune disorders. The Sjogren's Foundation, and you can look them up online. They put out a monthly newsletter called Moisture Seekers, appropriately termed, and they're a great source of information for the Sjogren's, and they can give you different opinions and clinical studies that help with their with the dryness and other manifestations. The American College of Rheumatology is always very helpful. National Institutes of Health, two areas in particular, NAMES and NIDCR, are good sources of information if you're having significant symptoms and don't have anywhere to go. The doctors that are experts in Sjogren's are rheumatologists, and I think most physicians are probably aware of Sjogren's, but maybe not to the extent of the extra glandular manifestations and things that we have to keep an eye on. After everything that I've discussed, in the 28 years that I've been in practice, I've had 2 patients that have severe neurologic disease. And so I don't want anyone out there that's listening to this that has Sjogren's thinks they're going to develop severe disabling neurologic symptoms. Only 2, obviously very severe, and we have to keep an eye out for that. And I've had probably 3 or 4 patients that develop lymphoma. And as I mentioned, I've seen hundreds, probably into the thousands of patients over the years. And we're vigilant and watching out for these patients, but it's not a common thing. And then we'll end there and take questions from anyone that might have questions.
Dr. Santos, thank you so much. That was extremely informative. I don't think I've actually seen anything like that to correlate so many symptomatic disorders back to one particular disease. That was very well done. Let's jump into some of these questions. I'm going to ask the first question here from Lee Boyer. She says, my daughter was recently diagnosed at age 15, but has had extreme dry eyes and mouth since around age 10. Positive for SSA antibodies. Does being diagnosed so young equate to more severe symptoms as she gets older or a worse prognosis?
So as I mentioned in the talk, the most common age is 40 to 60, but absolutely children can develop Sjogren's syndrome. And so the longer you have the condition, the more potential for more severe symptoms. It doesn't mean that she's going to develop any neurologic or systemic effects. However, starting at that age, we need to remain vigilant for that. And so I would suggest that she find a good rheumatologist. Probably at her age, maybe she's seeing a pediatric rheumatologist, but then I think adult rheumatologists are probably more in tune with the Sjogren's condition, given that it's seen more often in adults. So I would remain vigilant, but it's not a given that she's going to be somebody that has more severe disease. Although if you think about it, she's going to have it for longer than most people because she developed it at such an early age. So that might be something that just predisposes to more severe symptoms.
Okay, thank you. The next question is posed by Julia Rojas. Is hydroxy tough on the kidneys?
So it is not. In fact, it's not one of the drugs that we really monitor kidney function. Hydroxychloroquine, the manifestations we mostly watch out for. Rarely somebody might get what we call a hydroxychloroquine rash. It's like an allergic reaction, so I always tell people to be careful with that. We want them to monitor their vision, and the eye toxicity is something that there are excellent guidelines to look for and make sure that there's no eye problems. The risk of eye problems is about 1% after you reach 1,000 grams of the drug, and if you're on 200 twice a day of hydroxychloroquine, that takes about 7 years. Now, the other thing is it can cause pigmentation and rarely muscle problems, but kidneys are not a problem, generally.
All right. Thank you. Next question by Marlene Helm. Was diagnosed with lupus in 2009. This year was told I had Sjogren's instead. Was I likely misdiagnosed? Was told to continue hydrochloroquine? Thank you.
Yeah, excellent question and observation, and that actually happens a lot. that somebody is misdiagnosed with lupus when they actually have Sjogren syndrome, because the manifestations are somewhat similar, yet we see high SSA, SSB antibodies in patients with lupus and Sjogren's patients, but I've had that happen many, many times. And the good thing is Sjogren's, while not a totally benign condition, overall is generally more benign than lupus. And so I'd rather tell a patient they have Sjogren's than that they have lupus. And a lot of times there can be overlap. And as I mentioned at the beginning also, that Sjogren's can be primary, and that may be what you have, but it could also be secondary. So patients can have lupus and Sjogren's syndrome. Now, my recommendation is to see your rheumatologist, and they can definitively differentiate what's going on. And I've seen that many times in the past. In fact, I diagnosed a patient with lupus and then changed my mind and said, no, this is all Sjogren's, after I was able to follow her for a while and see no progressive condition suggesting lupus.
Wow. There you go. Next question by T. Spencer. Why does this syndrome appear to impact more women than men?
That's a great question, and we don't know. I can tell you that estrogen, and it seems to be a promoter of autoimmune disease, and the androgens are somewhat protective, and that may be part of it. Androgen is like the testosterone and male hormone. We see that with a lot of other conditions like lupus and rheumatoid arthritis, and so a lot of these autoimmune diseases are more common in women. The exact reason is unknown, and we're hoping to maybe in the future know more about that. But I think estrogen and the androgens play a role.
Yeah. Next question by Safa Belgari. I'm sorry if I'm butchering that name. Her Sjogren syndrome attacked badly her skin, especially her face and neck, which is apparently not common. She has a full and terrible flare-up for nearly 14 months straight. All skin was on fire, suffering from cutaneous eruption, skin rash, red patches and pimples that appear suddenly, itching, and many weird symptoms. I took Plaquenil and cortisone, but it doesn't work. I feel so confused.
So that's not a common manifestation of Sjogren's, but there are certainly many other conditions that occur with Sjogren's. And I mentioned vasculitis. Vasculitis can involve the skin. I showed a picture of purpura. My suggestion would be to see a dermatologist and maybe a dermatologist that specializes in autoimmune conditions. In Michigan, we have a couple at the University of Michigan that we can refer to. The most important thing would be to have the skin lesion biopsied to find out exactly what it is, because there are things that are autoimmune and not autoimmune that could cause that. There are stronger medicines than hydroxychloroquine, but if the steroids do not help, I'm wondering if there's not something else going on that may require other therapy, because steroids frequently will clear up most or at least help most immune type of skin reactions. And if you were put on steroids and it didn't work, I think a biopsy is necessary to definitively determine what's going on there.
Thank you. Does changes in weather and heat irritate Sjogren's? By Anne Marie Klosko.
Well, certainly the more arid climates are going to make things worse. And cold weather, if you have a heater at home, and in Michigan we have humidifiers, if your humidifier is not working, that certainly will aggravate the symptoms. I can tell you that I have patients who go to Florida from Michigan. I live in Michigan, or go to Arizona when they have a lot of joint pains. They a lot of times, for certain autoimmune diseases, they feel better. They have less joint pain, but that's as far as their clinical symptoms. The dryness, it really depends on the climate and the moisture. So in high humidity areas, they tend to do better.
Well, Okay. Is there a resource that helps you find a rheumatologist that specializes in Sjogren's by Amanda Sewer?
Yeah, so most rheumatologists are familiar with the condition and can treat it. If you're looking for you have more complicated Sjogren's and you want somebody who is highly specialized, talking to one of your universities, tertiary centers, calling the rheumatology department, you can get information there, possibly through the Sjogren's Foundation. They can tell you who's doing the clinical research and publishing for Sjogren's, and those type of resources I think would be very helpful.
Excellent. Next one is by Marlene Helm. I don't believe we talked about the heredity factor and would like to know more about cause. If you have had this disease for 10 years without increased symptoms, will it likely get worse as you get older?
Yeah, that's an excellent question. I can tell you that a lot of my patients do have progressive symptoms. They start out where it's mild and then it gets worse over time. But I have those patients that kind of stay pretty stable with treatment, and they're able to control their symptoms with some of the over-the-counter and prescription medications that I mentioned. This is an autoimmune disease. There is a hereditary factor, and it hasn't really been totally outlined, but it can be seen like many of the autoimmune diseases in families. And so I think the important thing is to follow the recommendations of your doctor, treat the condition, make sure that you don't get any of the secondary problems from the dryness, erosions in the eyes and the cavities and severe problems in the mouth and esophageal problems. Try to treat what you can and follow closely with your rheumatologist.
Thank you. Next question by Anne Marie Klosko. What dietary changes do you recommend to help with the inflammation?
Thank you for that question. And for the sake of time, I didn't include anything on diet, but diet is really playing a major role in autoimmune disease these days. And they've actually isolated all the bacteria that is found in the human gut. There's about 3 pounds of bacteria found in each of us, and we know that your intestinal flora, the microbiome, plays a major role in autoinflammatory and autoimmune disease. So a lot of the bacteria that we have in our gut that you can't grow in culture, and they can only isolate it using special procedures. We know that there are certain bacteria that cause inflammation. There's a couple bacteria, for example, that have been isolated in the guts of patients with rheumatoid arthritis, Prevotella copri and Pseudomonas gingivalis, found in the gums, and that certain diets, simple sugars, a lot of red meat, promote the growth of these inflammatory bacteria. So nowadays, and you'll be hearing more about this, and that's actually a nice lecture. You might want to find somebody who's doing clinical studies on inflammation and diet. Very important to follow an anti-inflammatory diet. We kind of like a Mediterranean diet. There's a lot of grains in the Mediterranean diet, so you have to also be aware if you're gluten sensitive to avoid those type of things. But no question, if you eat a lot of sugar, a lot of simple sugars, it actually, you feel worse and you have increasing pain. So diet is a very important component to any of these autoimmune conditions.
Very good. Thank you. Next question by Lee Boyer. Does Sjogren's come in flares, like remit, relapse? Does it ever go into remission or go away?
It does come in flares, and not only the dryness, but also the joint pains. And sometimes there'll be a run and you have severe symptoms, and then things get better. I do have patients that do okay with treatment. Do they go into remission? I suspect that some do, but it's not the most common thing. With rheumatoid arthritis, we see maybe 10% of people that develop classic rheumatoid arthritis go into remission. I don't see that as much with Sjogren's. Why? Mostly because the symptoms are the dryness, and so a lot of times these patients are using the artificial tears and artificial saliva, and they just don't complain as much. They might get a little bit better, but I don't think that it's going to go away completely.
Outstanding. This is more of a statement, but I want to pay homage to Safa. Thank you. I was diagnosed 5 months ago at the age of 27, and I already visited nearly 8 dermatologists before my diagnosis with Sjogren's, and unfortunately, they provided me different diagnoses. It seems very complicated, she said. And that was our last question for the afternoon, but I did just want to get that out here since Safa's been very engaged. Oh, look, I think Lee just popped up another question. Let's see here. My younger daughter also has SSA antibodies, but is asymptomatic. Does she really have Sjogren? Is that a possibility, doctor?
No, and that's actually an interesting subject, because a blood test doesn't diagnose a condition. However, SSA antibodies have other concerns that I didn't get into because it's outside the realm of Sjogren's. But women of childbearing age that have a positive SSA antibody need to be vigilant when they get pregnant, because there's a 1 to 2% chance of congenital heart block in the baby, and also 1 to 2% chance of neonatal lupus. Congenital heart block is where there's abnormal conduction in the heart, and it could cause fetal loss. So if she has a high SSB, she should let her OBGYN know when she's going to conceive and have children, and they need to monitor her a little bit closer. Interestingly enough, we've talked about hydroxychloroquine. We're using hydroxychloroquine in these patients that are SSA positive, and it seems to prevent the development of this congenital heart block. So that's something that she needs to see somebody who's in tune with that condition. Also, the neonatal lupus, it can prevent it. Now, neonatal lupus is not something that is of any major concern. Generally, it lasts for 2 weeks, you get a rash, maybe fever. The child's irritable, but it doesn't turn into adult lupus, or it doesn't have any of the major manifestations of lupus.
Excellent. Well, beautiful explanation there, doctor. And that's our last question for this afternoon. So thank you, Dr. Santos, for being with us and volunteering your time and expertise to educate our community. And thank you to our audience for listening to today's presentation. And don't forget to tune in next month to our next month's webinar on June 23rd for Chronic Illness 101, a young adult patient perspective, with University of South Carolina Honors College sophomore Jessica Goddard. Please take a moment to fill out our quick survey at the conclusion of today's webinar to help us better serve our patient community. Also, if you enjoyed today's presentation, please consider making a tax-deductible donation to AAIDA. You can do that by going to our website at www.godoaida.org. Your contribution helps us to be able to conduct the educational initiatives such as today's webinar, and to be a valued resource for our patients and medical community that we serve. This is Ken Newbill for Advocacy and Awareness of Immune Disorders Association, and we hope you have a fantastic evening and a great weekend. Thanks so much for attending. Take care.
That was excellent.